Good afternoon, everyone. I'm Maggie Walsh, and I'm here to present NovaKone to you, Maximizing the Experience. I'm going to do a little bit of an introduction here, and then I'll bring up all the rest of my friends to wow you with their case studies. So, Alden Optical, we saw an opportunity to come up with a soft lens that would help your keratoconus patients. And our target was GP-intolerant patients, or at least limited wearing time with GPs. Maybe they failed with hybrids or sclerals, and they just needed another alternative. So we knew that these people were getting their vision corrected, but they needed that comfort. And unfortunately, we didn't have anything out there that was stellar, so to speak. So this is a cross-section of the lens. You can see on the back surface there are two curves. There's really three curves, but two that you need to be concerned about when fitting the lens. The base curve is there to create an optical alignment, and then the fitting curve is there to do your actual fitting, your physical fitting of the lens. There is an aspheric front surface, and there are 5 different thicknesses to the lens. We call it IT, or index of thickness. Then there is our fabulous dual elliptical stabilization, and that's a process that we do to the lens to make it toric, but also to keep it stable. We have up to a 10 sil in this lens, and if you asked Charlie to make something more, he probably would. So what makes NovaKone work? Pretty much all of those things combined make this lens work very well. It's the unique different thicknesses to neutralize the irregularity on the cornea, and then that unique design that we've come up with, and then the dual elliptical stabilization. So these are the parameters. It's right now it's a Benz material, or a high oxysilicon D. Standard diameter is 15, but we can go smaller or larger if you need it to be. Base curves from 5.4 to 8.6, and anything in between. We can probably go a little steeper, a little flatter if you need to. Fitting curves, also same thing. We can go anywhere in between. We do 8.2, 8.4, 8.6 are standard. Plus or minus 30, that's a really big thing, and then up to a 10 sil around the clock for axes, and then 0 through 4 for thicknesses. Just so you have an idea, the 0 is a 0.35 thickness, 1 is a 0.45, 2 is a 0.55, just that way. So we do have a diagnostic set. It's 18 lenses. There's 6 different base curves, and each base curve has 1 fitting curve, and then it's in the set with 3 different ITs, so you can vary that. They are all dual elliptical stabilization, but they have 0 sil power in them, so it's very easy to assess your over-refraction with that and look and see how much rotation you have, if any. So we do a 4-step process. We fit from the inside out. First we determine the base curve and then the IT factor, and then at that point we decide to do the over-refraction and figure out the power. And the very last thing that we do is decide if that fit curve that's on that diagnostic lens is actually the one that you want to use. And we'll go through that real quickly too. So to select the base curve, we want you to use this nomogram. We worked very hard on this nomogram, so we want you to stick with it. At least it gives you the first lens to try on. So you're looking at the average central K 3 millimeter area. So if you're using topography, make sure you're concentrating on that 3 millimeter area. This is strictly to create an optical alignment. So you're not taking into consideration how steep that cone is. And this is what you'll do. You'll use Fluorosoft. We use high molecular weight fluorescein. We put a drop of that in and a few drops of saline, insert the lens, and see what you get. So the first picture, obviously, too steep. There's excessive pooling there, and you can see in the optics section that there's just way too many tears. That patient's not going to see very well. And the second one, the acceptable fit, on first glance, you might think that looks pretty flat, but if you look at the optics section, you can see there are tears getting all the way through over top of that cone. So that's actually ideal. We want this lens to fit as flat as possible, but still get tears all the way underneath that lens. And then the flat one is an obvious flat because you can see right there at the bottom, over top of the cone, there's no tears. Then we decide on the IT factor. And there's a few different ways you can decide that, but most of it is done by verifying it with your keratometer or topographer. So we recommend the thinnest possible that you can get away with. If it's in a mild cone, I usually start with a 0 on one eye and a 1 on the other. And then I evaluate the Myers and decide if I need to change anything. If it's highly irregular or very advanced cone, I might start with a 2, a 1 on one and a 2 on the other. But then I put do the topography or keratometry over top of the lens and evaluate the Myers. So see, the top picture has no lens on. There's not a lens on there. And then the bottom two pictures, there's the NovaKone lens on, and see how it crisps up those Myers. Then you know that you're going to get a pretty good reading, a pretty good over-refraction on that. You can also do topography, but bring up those ring images so you can compare and see what those look like and see if you've improved them. So once you've decided on the base curve and the IT, you can go ahead and do your over-refraction. And the reason for that is that if you change the base curve or the IT, you will change the over-refraction. So you need to make sure that you have the correct one on when you do your over-refraction. Let it settle for at least 15, 20 minutes before you do the over-refraction, and then just compensate for vertex distance and any kind of rotation that you have, and just write that down and move on to the next step. The last step is the fitting curve. And we only have one fitting curve for each base curve in the diagnostic set. So it's going to be your call as to whether that is actually the correct fit curve for this patient. And the way that you determine that is by taking a look out there. And you probably already looked out there, but at this point you're going to just see if you have any edge lift, or maybe the patient is saying when they blink they feel that lens. Then you'll just order a steeper fit curve. And in the other direction, the same thing. If there's little or no movement and it's almost starting to impinge already, then you're going to order a flatter fit curve. We want you to change it by at least 0.2 of a millimeter. You can change it more than that if you need to. If it's excessive, certainly go in the other direction. But for the most part, that's where you come in and make that call. Otherwise, we'd have a 50 lens set, which we didn't want to get into. So now I'm going to move on to the next part of our show, and I want to introduce Michael Ward. He is on the faculty of the School of Medicine and the Director of Contact Lens Services at Emory University, and he's going to bring everybody else into the program. Thank you.
Thank you, Maggie. Well, I'm not going to do much here except introduce the next speakers. And I have the pleasure first of introducing Dr. Susan Resnick, who's in the group specialty practice in New York City and Long Island, and a diplomate of the cornea and contact lens section of the American Academy of Optometry, and a consultant, author, and lecturer. Susan?
Thank you, Maggie. So being from New York, this is a relay, and I talk very fast, so I'm going to get the team off to a fast start. I suspect that's why they had me going first. So this is a very typical case. It's a post-LASIK ectasia. This happens to be one of my not-so-crazy patients. When I say that, we see a lot of type A patients, and she was actually is actually a pleasure to work with. She was calm, and her expectations were realistic. So this is really, I didn't have to do a lot of hand-holding, but she was a fairly complicated case, as you're going to see by the history. What was interesting is she was referred in 1998. She was 6 months post-LASIK, and she was told she had post-LASIK ectasia. But in speaking with her, my suspicions, and I do not have the pre-op numbers or the topographies or anything, is that my suspicion is that she was a form frust keratoconus before I actually saw her. Because her history was of having, they were never able to correct my left eye. I'd been in many lenses. I had originally worn hard lenses. Then I went to soft, and I was never happy. So what did I do? I went and I had refractive surgery. Okay, so she came in, and very typically she says, Dr. So-and-so referred me. He told me you need to fit me with hard lenses. And so that was probably true back in 1999 when I originally saw her. But one of the things I think you guys should be gleaning from this discussion is that that's no longer true. And my suggestion is to speak with your referral sources. Let them know that you fit a variety of different modalities so that they're not sending the patient in with a preconceived notion of what you're going to fit them with. It really makes the explanation and the discussion with the patients easier because we do have options like this. There are other options as well, as you know, but it doesn't tie your hands, much the way surgeons don't necessarily want you sending the patient back to them saying you must fit them with such and such an, or, implant such and such an IOL. But anyway, we took her through a number of different things. She had originally worn hard lenses. She came in thinking she was going to get them. I saw no reason not to start there. I originally fitted her with an interpalpebral design. She did okay for a year. Her vision was good. Her comfort was okay. The problem with her is she had very fragile epithelium on one eye. I couldn't identify the cause. No matter what I did to improve the fit, she just had too much staining, and we abandoned that. We did go to some hybrids for some time. She did very, very well with those for a while, but her tolerance to them decreased. My suspicion is that it was mostly due to dry eye things. She just wasn't getting a full day's wear. So this being what I call my back to the future case, because I went inside out, I went from hard lenses to soft. As her corneas were getting worse, I was going opposite of what you would traditionally think you would do. So then I said to her, okay, let's take the lenses off. We did a washout period. Let's see what your refraction is. I went to hydrogel torics. Her worst eye, which you're going to see in a minute, is her left eye. Then I went to silicone hydrogel after that, but because her left eye continued to advance a little bit and we didn't have the sil we needed, we abandoned that. So let me get to the meat here. She was back in 1999, 20/30 plus, 2200 in her left eye. Very typical, traditionally, as you'll see, look at the Ks here. She had 3 diopters on the right eye when we did keratometry. I think these were even sim Ks, but yet refractively, she only had a diopter and a quarter. You'll see that a lot in early cones. You'll see that in a lot post-ectasia. And as you know, the reason is often the cones are very decentered. The cylinder hasn't yet hit the nodal point of the eye, if you will. So I'm going to fast forward. 2011, we had her in at that point. She was wearing actually a silicone hydrogel in one eye and a PC toric in the other. Because I had to increase the sil. And this was her refraction. She had tripled, and you would have predicted it, based upon the Ks, that now subjectively she was taking about triple the cylinder. Her left eye, the cylinder remained the same, but the sphere increased. And what happened with her topographically, and I'm going to show you that now, is that the cone almost became more of a globus thing. It started to take up much more of the pupillary axis and the refractive axis. And she had been wearing soft torics, and she was pretty comfortable. But she was, one of these patients said, look, I'd like to see better, and what new do you have for me? I mean, our patients are almost trained to come in asking for new things. We want them to ask about new technologies because that's how we differentiate our practice, as do you. So these are the topographies. These were the ones taken in May of 2011. And you can see there how much more of a global ectasia she had on the left eye, and hence, the difference in refraction and the difference in the degree of myopia. So with NovaKone, it's very straightforward. As Maggie alluded to, their fitting guide, their nomogram, is awesome. I can't tell you how many times I haven't had to go off the nomogram, rarely if ever. So I went strictly by that. I put the trial lenses on. She was an 8/6 in one eye, 7/8 in the other. I'm going to talk a little bit about IT and how I select it in just a couple of slides. The one thing also about this lens is the auto-refract. If you let those lenses settle, the auto-refraction, at least in our hands, in our practice, is very accurate. It saves us an inordinate amount of time using the auto-refraction, in the phoropter in a trial frame. It just cuts down on the subjective because the lenses do take a while to settle. And, ectasia patients or corneal irregular patients have a hard time with subjectives anyway. So it's just wonderful to have an objective tool and a great starting point. The dual stabilization, in my mind, is the key to this lens. I don't think I've ever seen more than a 10-degree rotation. She happens to be one of the patients whom we had it in one eye, but it was, it was consistent. It wasn't rotating, it was just orienting 10 degrees off. So it wasn't one of these things. It was always in the same place. So very simply to do the over-refraction. The other thing I will tell you, just to give you a little bit of learning curve, when I first started fitting these lenses, my mistake was that I was over-minusing them. I don't know if it's just me and the way I refract, but I learned very quickly that the settling, it's either something to do with accommodation or the tear film or the movement. I can't tell you what it is, but just be careful to push plus. It'll really save you time. I ordered and dispensed just as my over-refraction would have suggested. I picked an IT of 1 for the right eye, a 2 for the left, compensated, so ended up ordering 10 degrees less on the left eye. Her final visual acuities were excellent. This over-refract was actually from the auto-refractor, which I was really pleased with, and so was she. If I was a real scientist, which I am not, I might have tried an IT of 3 on the left eye to see if I could get her to 20/20. But in real life in New York, if the patient's happy and they're seeing 20/25 and it's a thinner lens, you're going to stop right there. So she currently wears the lenses 13 to 15 hours a day. We haven't seen any adverse effects. I am typically using peroxide solutions to dispense these lenses. That's not to say you can't use multipurpose. I've just found that many of our patients are very dry, and many of them do have sensitivity, and it is a thicker lens, and I'm actually happy to have solutions that, there are no preservatives, so they do quite well with that. This little chart was something that I literally took off the top of my head. At one point, I sat down and I sort of asked myself, well, how am I deciding which IT to start with? Understand that this is my first diagnostic lens. It's not necessarily what the patient's going to wind up with, but I needed to have a little extra nomogram in my head of, well, how do I decide if it's a 0 or a 1 or a 2? And so I jotted it down and I sent it to the Maggie and et al., and they decided to put it on a nice little slide, and it works for me. And again, you're always going to use the thinnest lens that you can. There are obviously topographical factors that would suggest to you you're going to go differently. That would be the size of the cone, if you will, the relation to the pupil. Certainly the presence of corneal scarring is going to, throw it off. But this assumes a pretty pristine cornea with just mostly irregular stigmatism, and it is devised based upon how the cone looks to me on the topography. But mostly, I go by what the best manifest refractive acuity is, and that's really what this speaks to. So that's the story of my post-LASIK ectasia patient. Thank you. We instill it much the way we would do if we were using a hybrid lens or a scleral. We put just a tiny bit of high molecular weight, mostly with saline, just enough to be sure that you have that even flow, as Maggie alluded to, and that you don't have too much touch or too much apical clearance. So just a drop or two and the rest saline.
You had mentioned that you allow your lens to settle for quite some time. What is that?
Well, in our... the question is that I mentioned that I allow the lens to settle for quite some time. In New York speak, that's 10 to 15 minutes. I had been doing it at 5 minutes, and I said no. First of all, it makes it way too easy, and I can't charge the fees that I want to charge. Oh, you didn't hear me say that. Okay.
Any other questions? Yes, ma'am.
This is a custom lens, so you can order any base curve you want. Where you're going to veer from the fitting set, as Maggie spoke to, is the fitting curve. That's that paracentral curve. And yes, if the base curve looks good and I'm happy with my IT, but that lens is jumping, which is more likely than the lens sticking, I will steepen up the fitting curve by a minimum of 0.2 millimeters. So yeah, I would say maybe 20% of the time. You have to remember that it's, you're going to look at your sagittal depth too when deciding on this. So your larger, steeper, corneas are going to require steeper curves all around. Often you'll make the change in the correct proportion to the base curve, but sometimes you have to steepen the paracentral curve a little bit more than you would have thought otherwise. Well, if it's not in the fitting set, I will then, yeah, that's a good question. What do you do? Close, glare. No, in other words, steeper than what's in the fitting set, you're starting to go empirically, is that what you're asking? Okay. The set goes very, very steep. I haven't had to do that. But you do have to take those extra few minutes, and you do have to re-refract. It's not like a hard lens where you're going to go 0.5 of a millimeter and make half a diopter kind of thing.
And you mentioned, Susan, that you go very much by the nomogram.
I do.
And I like your table.
Well, thank you.
That you created.
It actually does work, and I look at the topography, but I know if I have a 20/20 patient, they're going to be a 0, the most a 1 in this lens. I mean, it's intuitive, but sometimes intuition works.
What do you think of these parameters? What are you using most commonly as far as thickness and a base?
That's another great question, and if you show up to the 9 o'clock paper on Sunday morning, you'll have the answer to that. But let me give you the short answer. 65 to 70% are in the 1s and 2s in terms of IT.
That would make sense.
I agree with you wanting to use peroxide, but in the past, I know with like much thicker lenses, there's been a concern about not being neutralized and then leaching out. Have you had any toxicity?
No, I haven't, but now that you mentioned it, I'm going to be aware. No, I have not. And I don't know why, but that's good.
And how much movement? I'm sorry.
Yeah, that's a good question. So these lenses don't fit like your skinny little, everyday, traditional disposable lenses that we're using now. They do move more like the old-fashioned lenses that I grew up with. So you're seeing about 1 millimeter, of movement, sometimes 2 millimeters of movement. It does have to move a bit. First of all,
critical.
It's critical to the corneal health, right? I have not seen any neo from these lenses. I haven't had any real, I shouldn't say that. When I was on my learning curve with this lens, and I wasn't paying as much attention to what I was supposed to be doing and thought I knew how to do it until the nomogram taught me how to do it, if you have too much touch, you will see, increase of swirl stain on cones. Am I correct? So that's why you do want to have a good, some tears under there.
If you had a well-fitting soft lens for keratoconus and a well-fitting hybrid, which is more comfortable?
Did everybody hear the question?
Please repeat.
Does anybody want to answer the question? Okay. That's, I think, patient-specific and patient-dependent. I mean, if your practice is like mine, as I always say, you can't have too many choices. I mean, I'm happy to have hybrids. I use them for lots of patients. I'm happy to have this lens because many patients can't wear hybrids. Many patients don't see well out of, as good as this lens is, it's not going to work for anybody, but you can say everybody, but you can say that about every lens. So a well-fitting hybrid, as we know, is very comfortable. It gives good vision. But there are patients who, let's think of it this way. You have your patient's history, and if they come in and say, look, I went for laser or I did this because I never wanted to wear a lens and everything hurts my eye, I mean, I would probably try to start with a soft lens. These patients don't even want to wear lenses to begin with.
This is for everybody in the Hanover.
When we're diagnosing young men, 13, 14-year-olds, I love to put them in this lens because they're active, it's not going to fall out, they're going to have an easier time with insertion and removal. It's a very easy lens to insert and remove. That's one of the things that we like about it.
Any other questions for Susan? Sorry, Susan. Susan?
hear my head shaking? No. And again, I'll be doing a paper on this Sunday morning, but you have, this lens in my hands has worked on 20/60, 20/70, 20/80. We've got many of those patients to 20/40, 20/30, some to 20/20. So no, this is purely just where you're starting, your first diagnostic lens. So you can take that 20/60 patient, and for somebody like that, I'd probably be using an IT of 2 or 3 as my initial lens, and then go from there. But it is amazing how once you correct that corneal irregularity, what you're going to notice is that the amount of cylinder that you now need to put in that lens is so much less than you would have thought. So you're getting rid of the irregularity first, and then the rest is true residual refractive error, and that's where the toricity and the stability of the stabilization is the icing on the cake.
Thank you. Thank you very much, Susan. And next, I have the pleasure of introducing Dr. Bruce Baldwin, who's from the University of North Carolina. He got his OD and PhD degrees from the University of Alabama. We're talking about the Deep South and enjoying the high humidity and heat during the summer, particularly in August. He's at UNC right now. He's and also a founding member of the Scleral Lens Society, which is a wonderful thing to do. Thank you, Bruce.
I like the high heat in Las Vegas, but for me, who grew up in Alabama, they don't have enough humidity here in the summertime. So thank you all for coming out, and thanks to Tom Schoen and Maggie Walsh for inviting me to be part of this panel today. I'm really happy to be here. I fit a number of the Alden prosthetically tinted lenses over the years that have really changed a lot of people's lives, and I'm a really big fan of the NovaKone also. So again, I'm really pleased to tell you about this one patient. And when I was trying to come up with a title, I actually had the word surprise in the title at one point, because you're supposed to see better, a keratoconus patient is supposed to see better with a rigid lens than a soft lens, and I was quite surprised when this patient saw better with the NovaKone than he ever did with any rigid lens I had him in. And so that's the one surprise, that he saw better. And there's actually a second surprise with this patient, and I'll tell you about that towards the end of the talk. So our patient is 65 years old, a little bit older for a keratoconus patient. A lot of those patients, have already had a corneal transplant at some point in time. But there's still quite a few older keratoconus patients out there that are still seeing fairly good with rigid lenses. Now, this fella, even though he's 65, he was a competitive tennis player. He was very competitive. Him and his doubles team won tournaments around the state of North Carolina and beyond. So he's a very avid competitive tennis player. And he's worn rigid lenses for 30 years or so, maybe 40. He was fit when he was in the Army at the age of like 35 or something like that. And with the RGP lens, he could always see pretty good with the right eye, around 20/25 or so. But I never could really get him seeing any better than about 20/40 to 20/60 on visit to visit. Maybe occasionally he would squeak out a 20/30 minus, but never could really get that left eye seeing good. And as you'll see, I made changes and refits over the years and never could really get the left eye seeing okay. And he had chronic apical staining in that left eye, which was probably related to the limitation in his best corrected vision. Here's a spectacle vision, which was actually not terrible, but he didn't like wearing those great big thick glasses. And 20/30 and glasses like that in a keratoconus patient is really not very good vision. Here he is, in the right eye, the Myers look fairly good, although he has fairly advanced keratoconus in the right eye, and also on the left he has fairly advanced keratoconus. But look at the distortion in the Myers right here in the left eye, and it's the left eye that we're going to refit to the NovaKone. So when you have chronic staining and a little bit of anterior scarring, you'll often see a little divot in the a keratometric or a topography Myers that look just like that. And when you see that, that's not a good thing. Here's how he looked in that left eye when I first saw him, and it's common to have a new keratoconus patient wearing a small RGP lens that's fit very flat. And over my career, I've always tried to take those patients out of those flat-fitting lenses and gradually steepen the base curve to reduce the bearing on the cornea. And sometimes with 3/4 of a diopter or 1 diopter change every 8 months or 12 months or so, slowly and gradually steepen the lens to get a little bit more of an alignment or a minimum apical clearance touch. So there's 2006, and also in 2006, there's that chronic staining and anterior segment, anterior stromal scarring that also is very common with small diameter RGP keratoconus patients. And again, when you see chronic scarring, you've got to do something because that patient is going to develop a larger scar over the years. So fast forward to 4 years, and now I've gone through several refits, and this is again still the left eye, and the lens, I think, looks a lot better. I've got a fit that I think is almost aligned with a little bit of apical touch, and I've spread the bearing of the lens over the entire cornea, and it moves well. Everything you can say about that lens is what you would desire as a practitioner. However, you take the lens off, and you're still getting this chronic staining. And if you could see, maybe with a bigger image, you would see a little bit of swirl staining here. You've all seen swirl staining from RGP lenses. When the eye blinks, there's a rotation of the rigid lens, and it causes these little swirl patterns. But again, this little hot spot right there, that's bad, and you really need to do something about an eye like that, or you'll increase the scarring over time. So let's try a NovaKone on this patient. And here is the mean K from topography. It's about 5325 diopters. And according to the nomogram, it fits right in between the 7.0 base and the 7.4 base. And I typically fit these lenses flatter. I found the movement's a little better and the vision maybe is a little better. So I picked the 7.4 base curve. And that 7.4 in the fitting set has the 8.4 fitting curve. You know, that's the mid-peripheral or the peripheral curve, the fitting curve. And the 8.4 fitting curve in that lens, although it fit good otherwise to me looking at it, had a little peripheral bubble. So I ordered the same 7.4 base curve, but I flattened that peripheral curve to the 8.6, hoping that that would eliminate that peripheral bubble. I used an IT2 because that was the trial lens that I tried. And if you haven't heard it already, you should know that if you're going to change IT, make sure you put the next IT on the eye and do another overcorrection. So I ordered the 7.4, 8.6 with the IT2, and based on the overcorrection, he just needed a spherical -9. And I will tell you that I fit a lot of toric lenses, and there's no problem at all ordering a -2, -3, 350 cylinder, and they work really, really good. But in this case, he just needed a spherical lens. And just to show you, this is his right eye, and he's wearing a piggyback to this day in the right eye. There's a small diameter RGP, and if you've never seen an OCT image of a piggyback, I thought I would just throw this in here for you for your viewing pleasure. There's the RGP lens on top, and there's that soft carrier lens underneath the RGP. That and that is simply an artifact from the anterior segment OCT. So he continues to wear the piggyback in this eye, and he's still seeing good, like 20/25, almost 20/20 with it. And we've talked about whenever this RGP wears out, we're going to go ahead and refit him to a NovaKone in that eye because he likes the one in his left eye so much. So here's the left eye with the NovaKone that I dispensed, and you know they're very thick. You can see in this image here, the NovaKone lens at an IT2 is actually thicker than his cornea, so they're quite thick. However, just looking at the eye, you can't really tell the patient is wearing a lens other than any other soft lens. If this were a toric lens, there would be a little drilled divot right here on either side, letting you know the alignment of the toric prescription ground into the lens. So there's the lens, and when I dispensed it, he was 20/20, and he was 5 out of 5 letters on the 20/20 line. And again, in 5 years, he's never been any better than about 20/30 or 20/40. And I can't really explain that. I don't know why that's the case, but I was very happy to see it. And after he wore the lens for about 6 weeks, I think I saw him for 2 follow-ups, he ordered 3 additional lenses in the same power, and we're going to do quarterly replacements. Here's just another view of the NovaKone on the eye. This is the vertical cut from the OCT, again showing you the thickness profile of the lens on the eye. And if you can tell from where you're seated, you can see the cornea and then the contact lens sitting on top of the cornea in that sideways view. So here's some of my pearls. You want good movement on the lens. Again, I tend to feel a little bit flatter, and I like to see a lot of movement. It's been mentioned earlier, these lenses were around 30 years ago, but they were made in very low decay materials like polymacon, and they tended to get really tight, and all those eyes got hypoxic, and that's why they pretty much quit making them, and you and I quit fitting them. However, we have the higher decay materials now, like the hydroxysilicon that the NovaKone comes in, and also with good movement, you're assured of getting really good tear exchange under the lens, and I think that's key for maintaining good corneal health. Let it settle. Let it settle, because I think maybe because the lens is so thick, over time there is some hydration effects with the lens, and if you want to get a stable over-refraction, let it settle for maybe 30 minutes if you've got the time. We saw earlier photographs of irregular mires on a patient with keratoconus, and then the smoother, more regular mires on top of the NovaKone. I don't do that because I'm really good with the retinoscope. So if I put a lens on an eye with an IT2 and I take out my retinoscope and it's a really crappy retinoscopy image, I often will not even over-refract that. I'll just take the lens off and put the IT3 on. Because if you put a lens on any keratoconic eye, and somebody mentioned the 2060, I've got some 2,400 patients that are seeing 2060 with the NovaKone, so I wouldn't let visual acuity limit the type of patient that you choose to fit. But if I put a lens on the eye and I'm getting a pretty good retinoscopy reflex, I know that patient is going to see good, and right then I know they're going to end up wanting that lens when I show them the vision through the phoropter. Don't forget to use the corneal plane refraction added to the power of the lens. If you have some lens rotation and you have a toric over refraction, if I've got just a little bit of rotation, maybe 15 degrees, I don't make any rotation corrections because they may line back up a little bit better with the final lens. But if it's like 20 degrees, I'm probably going to send the lab the lens, the trial lens, the overcorrection, and estimate the rotation and let them figure out what final power to send me. And again, the toric lenses are very stable and the vision is very good even with some of the higher cylinder powers. And use that fitting guide for the first try, because the fitting guide usually works well the first time. So I told you the surprise was that the patient saw 20/20, and you're not supposed to see better with a soft lens than a rigid lens, but this patient did. So here's the other surprise. So I did the 1-month follow-up, and the patient was seeing 20/20 with the lens, and he told me he's back on the circuit, and him and his partner won a tournament or two with tennis. And so he left, and I get a knock on my door. The front desk person says, this patient's wife wants to talk to you. Well, okay, so I go outside into the waiting room, and she comes up to me, and she gives me this great big bear hug. She's doing like this, and I'm looking around a waiting room full of people, and I'm like, okay, all right, this is good. I think this is good. And she says, I just want to thank you so much. My husband, he is seeing so good. He's playing tennis and he's winning. And I'm thinking, well, yeah, I know his vision's good, and I don't know what else has changed good in that relationship. But I only thing I can attest to is that the vision was greatly improved. So that's my one patient. The trial set is made exactly like a toric lens. It's cut with a toric design. It has the little drill divots in it. So when you put the lens on the eye, and they're almost always at 3 and 9 o'clock, or very close to 3 and 9 o'clock. And when you put a lens on, a trial lens with no toric power, but with a toric design, and the dots are at 3 and 9 o'clock, you know when you order toric power in there, it's going to sit right where it's supposed to and give you the intended power from the toric. Well, I like to do quarterly replacement for this lens, and I buy one. The patient buys one lens, and after a month or two, we make sure it's going to work okay. And forgive me if I'm wrong on this, but is there a price differential if you buy 3 more of the same lenses? You want to talk about that?
It's okay. Let's say it's a toric. It's 110 for the single, and when you upgrade to the 4-pack, it's another 110, and you get 3 more lenses.
Yeah, that's the way I remembered it. So, and when you tell the patient that, I say, okay, this lens is doing great. You know, for the same price of that one, I can get you 3 more, and it's like they almost all do it. So it's a great benefit for you and the patient. It's a extra sale for you, and it gets the patient a fresh lens every 3 months.
Bruce, I have a question. We also have a lot of patients that we're taking out of GP lenses and putting into these. From a practice management or patient management perspective, what do you do for these patients who are, let's say, in bilateral hard lenses? How long do you keep them out of the lens before you do your diagnostic evaluation? And do you fit one eye at a time?
Over my career, I've almost never taken someone out of their current lens for a period of time and then refit them into something else. Because, see, I go back to the days when I was seeing a lot of PMMA patients. And the worst thing you could do for a PMMA patient with spectacle blur and rebound is to take them out of their PMMA lens, and then every week they got a different refraction. So I just go with what they've had, take it out. I ask them to wear their lens in that day. There are a few exceptions. If there's some surface, if there's some surface problems, I'll have them wear their glasses in that morning. But I usually have no problem taking them right out of the lens that day and refitting them.
And then how many, you get the first lens in, and how many times are you changing it, let's say, within that first month or two, just on average?
You mean how many refits does it? Oh, this lens works. First time, every time. Next question? No, I don't know the numbers, but a lot of them do work first time. I think spherical lens, almost always the second lens works good. With toric lens, it may be like one and a half refits per eye, something like that.
Thank you. Any other questions, Dr. Baldwin? It's interesting that both you and Susan have mentioned let it settle. 15 minutes plus, and yet you were talking earlier today about you haven't got time in your practice to let lenses settle for more than 5 minutes.
That's what the waiting room is for.
That's right. That's exactly right. But I suspect we're going to see that same theme continue. So, again, follow the nomogram, let it settle. That seems to be a very important point.
Can I use this? Yeah. Okay.
And next, Dr. Chang from the Cornea Laser Eye Institute in New Jersey. He's from the Pennsylvania College of Optometry. He's an adjunct faculty at Salus University. And I have the pleasure if he's going to present our next case. Thank you very much, Dr.
You're welcome. Oh, so, actually I won't use this because I didn't realize the clicker's here. All right. I've just realized that everyone else is smarter than I am in this panel. Here I'm thinking that I'm closing the show. Now I realize I have 5 minutes to finish my case and everybody is taking a breather. So I'm going to try the best I can. I know I'm standing in your way of the entertainment and libation that's happening probably soon in exhibit hall. And this is going to be funny when someone's listening to the audio taping wondering what we do when we're away from our practices. So let me just set the record straight. We're learning, we're working very hard when we're away in a conference. Okay, so if I could just quickly before I start my case, if I could just very quickly give my comment about the settling time, and also I'm sorry I didn't get to answer that question about what happens when you fit outside of the parameter of your lenses. If I could just make 2 quick comments about that. If you're checking, if you're leaving sodium fluorescein in the bowl of your lens and you're letting it settle, please know that large molecular fluorescein will still diffuse through the stroma of the lens. So if you let it settle, it's going to be a little bit harder for you to look at the clearance underneath the lens when you put up your optic section with your white light, especially if you have only very little bit of clearance. If you have a lot of clearance, obviously it's not difficult. It's like a scleral lens. I mean, everybody can see it, right? So just make sure that if you want to let it settle and over refract later, before you let your patient go out into the waiting room, you ought to look at your clearance first. That's my experience, at least. Number 2, if I fit outside of the parameter, and whether it's flatter or steeper, and I have to say, actually, I've done flatter. I haven't really gone steeper. However, I have found in my personal experience, if you keep your IT factor the same, the over-refraction, whether I go steeper or flatter, is very similar. It's the IT factor, in my mind, that takes out the cylindrical component, and that's the part that's really hard to predict of how much you will take away when you go from an A2 to what's the next one, like 7/8. Right? So it's harder to predict that cylindrical component. You're going to pick up maybe a little bit more plus a little bit more minus as you gain your plus tier lens when you go steeper. But every time when I refract, when I put the initial lens of, let's say, A6, and then I feel like, I want an A2 before this patient leaves, I very quickly check with the refraction I got with A6, and it's almost always very similar for me. So I extended that when I actually didn't have any flatter lens to use on a more oblate cornea, and it turned out to be that way for me. So that's my experience on the extended range when you have to go out of the parameter. You still do the best you can with your over-refraction, and you can go a little bit more minus, a little bit more plus, depending on which direction of the base curve you're going. But it's typically very similar for me. As long as you keep the fitting curve the same, so the rotation's about the same, as long as you keep the IT factor the same. So if I would order the same IT factor as the last diagnostic lens you used. So let me just get into my case with a post-surgical use of NovaKone. And so the theme today is, I think we all have very old keratoconus patients. So this is this one patient who's 68 years old and who has had a history of keratoconus for about 40 years. So he's very aware and very obviously well educated of his condition, as many of our keratoconus or irregular cornea patients are. Whatever that means to our practice is a different story, but they're always very well educated, most of them. Complain about what you would expect, gas permeable lens intolerance. And so therefore, when he came to our center for surgical consultation, he actually had already stopped wearing contact lenses. He did not even show up with his contact lenses. But however, once he stopped wearing his contact lenses, he also is very unhappy with his vision, whether it's uncorrected or with his spectacle, which is basically the sort of the vicious cycle that our keratoconus patients go through. When you say, if you fit them well with contact lenses, what do they do when they take out your lenses? And that's why some of the patients stretch their wear time, because they have nothing to do with their life, if you would, when they're sitting at home without your contact lenses, especially if you slap their wrist and say you should reduce or limit your wear time. So I certainly think that patient psychology is something that, as Susan have mentioned in one of the questions where you're asking about what type of lenses would be better, a well-fitted hybrid lens or a well-fitted NovaKone lens or a well-fitted scleral lenses. The question is, we're at the best position at primary care level at figuring out what the patient is looking for and what's the best for the patient, because when they're at a surgical center, even where I am, a lot of times your surgeon doesn't get a whole lot of contact time with your patient, and they may make decisions one way or the other based on that first impression, whereas you can figure out, or we can figure out what the patient really wants, and so that we can help them the best we can. And so you've got to think that some of the patients who show up for surgery or some of the surgical patients are contributed by us as well, because if you look at this case of someone who's had 40 years of keratoconus, and you're thinking, hey, you've been stable, obviously you're a little outside of the natural course of keratoconus, where we tend to think that you stabilize around third or fourth decade of life. So many of us would probably have tried to continually push our patient to wear gas-permeable lenses because that's what was we think is the best for the patient. So this is going to do what? This is going to lead to a patient who comes to our center and say, could I have cross-linking or whatever surgery? I heard about this on the internet. So I think we need to spend more time to figure out the psychology of the patient, because that's when you can match their lifestyle, their demands, their visual habits with the best device they can be fitted. And that could be a NovaKone, that could be other device in different situations. So this patient was interested in collagen cross-linking. This is his entry exam with the result. And another lesson that I think that we have here is if you look at his best corrected, and by that obviously I'm talking about manifest, and very close to his habitual actually, is that he has one eye that's actually pretty decent for a keratoconus patient who's been diagnosed for 40 years. So again, what do most of us do? Well, if you're not willing to wear contact lenses, and that being gas-permeable lenses, which patients always come and say, well, I thought that was the only lens that I could wear, and I'm just so sick and tired of it. Obviously, I also have patients at the other end of the spectrum and say, my God, this feels so much better than the soft lenses that I was fitted before. So, again, not all lenses are for everybody. We need to know all the options out there. But the lesson here is that most of us would say, if you're not willing to wear contact lenses, your vision's pretty decent with glasses. So why don't you just do glasses? Again, that produces surgical patients that at times may not be necessary because we gave up on the patients first, right? So we educated the patient on the fact that cross-linking really mainly isn't a keratorefractive procedure, does not improve your vision, not as effectively as what the patient wants. So we offer contact lens refit. Patient declined. So we offer patient the implantation with Intex. And I know I already am seeing some eyebrows being pushed together when I say the word Intex. But again, it's what works best for patient. As long as the patient, my experience is that as long as the patient is well educated about their expectation and what we're trying to do to help them, they're typically very open to what you need to do afterwards. And whether or not there's challenges that is created by certain procedure versus others, I'm presenting a paper on Saturday to talk about it. So we can certainly talk about it some more either after today or after Saturday. But if you look at if you look at the left eye and the right eye, he's pretty decent in the left eye even with his glasses. So we only recommend it if he did not want to be refitted in another contact lens to then have the right eye treated with Intex. And we use an asymmetrical segment implantation strategy in his case. And you can see that his Kmax is about, as per PandaCam, is about 55, slightly over 55 diopter. And some literature have pointed to the fact that perhaps greater than 55 diopter for Intex, you may not get the optimum result. That hasn't really been the result of our center, but regardless, he's sort of borderline. So we treated him with Intex, and you can see that his uncorrected vision at least 3 months out had improved from 2100 to 2050. Okay, now obviously what this isn't revealing, and we all know that, is the quality of the vision. We're going by Snell and acuity, we're going by ETDRS. I understand that is quantity, not quality. However, if you look at the fact that patient could not wear anything other than his glasses and is not happy with his best of spectacle vision or uncorrected because he could not wear glasses or after he removes his glasses, you would understand why some people would appreciate what we consider as non-functional vision because it's 2050, it's not 2020. But for the patient, that could be a difference between being able to drive during daytime or not driving at all, right? So I think, and so you can expect a result. If I look at the pre-op, if you look at the 3 months, you can see flattening in the area and shifting in the area of the apex, restoring the some of the corneal sphericity, which is what this Intex is going to do. And if you look at the manifest refraction that I got, you can see the cylinder is reduced almost by half. And so he's quite happy with what he has. We referred him back to his primary OD who referred him, actually, I'm sorry, he came in on his own. So he went back to seeing his primary care optometrist who refitted him in hybrid lenses. So he now is coming in to say his contact lens tolerance has improved to all-day wear from not being able to wear gas-permeable lenses, soft lenses, not happy with the vision. Now he's in hybrid lenses. He's wearing them all day. However, he's recognized that he's mildly improved in his vision, in his uncorrected vision after Intacs, but he's not happy still with his contact lens vision with the hybrid lenses. So he's more complaining about blurry. He's not really seeing, the higher order aberration related symptom like ghosting, starbursting, diplopia, that kind of thing. And we thought, well, potentially some people would say, well, maybe there's regression with Intacs, which sometimes happens in the initial postoperative period. But if I look at, again, relying on my Pentacam, if I look at that, you can see 3 months later versus 9 months later, there has not been there's really insignificant, almost no difference in the topography. So because of that, if we look again, this is his data that day, 9 months out. There's a little decrease in the uncorrected vision, still better than the 2100 that he started with, a little bit less than the 2050 that we got at the 3 months mark. But also his left eye is not as good as before. So potentially just a day that keratoconus patients is a bad day for him, not a good day. I'm not sure, but the manifest refraction stays the same. So that tells us that there's really not that much of regression that has happened. So I looked at his contact lens. Could it be because there's some sort of positional or translational error due to that induces other higher order aberration related effects that we have to pay attention to? I looked at his lens. I feel like, in my mind, the lens fits really well. So normally I would ask everybody at this point, if anybody would be thinking about using a soft lens, given the fact that he's not seeing all that well according to him with his hybrid lenses. But I think the surprise is basically gone now because we already had 2 cases of refitting from gas permeable lenses to soft lenses. So I'm going to tell you why, however, I picked soft lenses. I did an over refraction on his current lenses that I did not fit. I did an over refraction on his hybrid lenses. When I put up the over refraction, he was ecstatic about the results. And it's not a whole lot of cylinder. And so you could see that basically the spherical equivalent is there with the hybrid lenses. It's the residual cylinder, whether it's from tear lens, flexuring of the lens, or whether it's from lenticular. Really we don't need to. If you want to, obviously you can use, manual keratometry to try to figure it out. And by the way, if you don't have placido projection system to look at the minor changes after you put on a NovaKone lens or any other lens device, you could use your manual keratometry, obviously, right? So given this result, I figured that with a residual cylinder, rather than doing some sort of front toric lenses in gas-permeable scleral lenses or other devices that I could name, I decided to try him on a NovaKone. So again, fitting guy, pretty awesome. At that time, however, it was the old fitting guy. It wasn't the revamped new fitting guy. So there was a possibility that for the right eye, and I like to use both my topography and my manual to sort of get an average and get a sense of which one I think I would like to go with a little bit more as a selection criteria for my contact lens. So I looked at both, and it potentially could be an A6, potentially could have been an A2. So I wanted everybody to sort of keep that in mind. But anyway, so this is the pattern that I was seeing with the alignment and a little bit more movement. So and similar for the left eye. So I went with like Bruce, I wanted to pick a flatter fitting lens at the beginning, and so I went with the A6 for the right eye rather than the A2. So let's look at what happened. So he came back, we dispensed the lens. There's a soft lens, he knows how to insert and remove, so it was relatively easy to just order it and mail it to the patient and have the patient come back. He reports even better comfort than his hybrid lens, but mainly probably because it's visual comfort. It may not be the fact that physically he's more comfortable, but visually he's seeing better, and that for a lot of patients means a lot. Again, patient psychology is something that we need to pay attention to as we are rehabilitating these patients. So anyway, he says the comfort's great. great. He's wearing even longer than the hybrid lenses. His contact lens vision, his vision with his contact lenses, there's no complaint. He's happy. And if you look at just minimum over refraction, I was getting the left eye to 20/20. And remember, left eye is the eye that was not surgically treated. The right eye was the worst eye, the more advanced keratoconus eye. I'm getting him to somewhere between 20/25 to 20/30. I usually like to document a little bit less than what I think the patient is seeing. Even if they guess at 20/25, they get it, I still feel like they're 20/30 and I would write 20/30. So I just want to point that out. But anyway, so you would think that I'm done. I mean, he's seeing great, he's wearing the lenses all day, and he's more better than the hybrid lenses that most people would probably not have anticipated. But here's the kicker. And also, this patient is of the personality where when he came in for his surgical consult, he actually drew his monocular diplopia for me when he's watching his TV. What happens, what ghosting image is seeing. So I just want you to know ahead of time, that's the type of patient that I know we all see. So obviously, this is not it, right? So the patient came in, oh, I'm so happy. This is 100% better than what I had before. Oh, but wait, I want to let you know that when I put on my glasses, and this is the part that I think we can do better. When I have to take off my lenses, because you told me I couldn't wear them all day, in terms of, more than 12 to 14 hours, and he wants to wear longer. So I stopped them maybe an hour before bedtime. But this is what happened. An hour or two, I don't see very well out of my glasses, and maybe only takes about 20 minutes. So he's reporting his, symptoms of spectacle blur. And remember, I went with the flatter lens according to the old fitting guy versus the new fitting guy that would have probably asked me to do an A2. So, obviously, mentally, I can understand what's going on, but I want to show you clinically and graphically what is happening. So I looked at his pentacam. So I looked at his cornea before I ever fitted him with NovaKone, but after Intax. And then I looked at that day. You can see that there's obvious bearing on the lens because the difference map is showing flattening over the apex. And so I went with the newer fitting guy, and I went with the A2 and with the following refractive changes. And the left eye, remember, he has about 20 minutes, so way less than the right eye. And you can see the flattening is there, but it's a lot less. So I made and Maggie hates me for making like a 0.1 changes. He said 20 minutes, and so I thought, okay, well, A5 rather than A6, just for fun. So obviously, when I'm doing this, I don't want to just go by what the patient is saying. I don't want to just go by the pentacam. I like to cross-check when I have time. And so hopefully then you're seeing this type of pattern with your sodium fluorescein. And remember what I say about the diffusing, the fluorescein can get soaked into the lens. So you want to make sure that you also check with your optic section of what type of pattern you're really seeing, and that you're not really just seeing the yellowing of the lens in the center of the material. So anyway, after he came back for his follow-up number 2, great comfort, even better vision than what he was expecting, he says, even though I'm not finding objectively on the chart any difference. But again, quality. That's what they're seeing. Now there's probably a reduced higher order aberration, which I'm going to show you what I got. Anyway, so the right eye, after I went from A6 to A2, no spectacle blur, not according to the patient. And there's with the left eye now, that 0.1 change in the base curve, he went from 20 minutes to maybe 5 minutes or 10 minutes. So I told him that I could actually just, should have probably done a 0.2 millimeter change. I'll offer it to him. I can do it just with the left eye that he wasn't having a problem with. He refused. He was so happy with the lens. He doesn't want me to take them away, regardless of what I say. So he said that he's happy with what he has. He doesn't want to do anything. And why should he not be? If you look at his, this is done over 5 millimeter pupil using the Alcon laser wavefront sensor. The top is is your HOA, higher order aberration from after Intax, and the bottom is with the lens on. You can see how much reduced the higher order aberration is with the final lens that I have. So I know I'm out of time. Pearls. So new fitting guy is likely way better than the old fitting guy, and obviously you're only going to, if you're working with a new set, you only get the new fitting guy. And don't forget that you could use sodium fluorescein as much as people, it's counterintuitive to check sodium fluorescein with soft lenses. Don't forget you could use that as a tool to troubleshoot. And also you could utilize topography if you have access to topography. It's not just placido disc and OCT and your manual keratometry. You have other tools that you can cross-check whether or not you are on the right path in terms of lens modification. And that, remember, even if other lenses fail, those that we think are gold standard treatment for irregular cornea, there still is possibility that a different type of lens can improve the vision and also reduce high order aberration even though it's a soft lens material, and therefore can be an option after someone who's had surgery, even like Intacs. And that's all that I have. Thank you.
Any questions for the end here? I know we're at the end of time, mid-stride, heading towards the door. Any other questions? Thank you very much for your attention this evening. Enjoy the rest of your time.